Hi, this is Jackie Whittemore, and I'm so glad to have you join me for Vice Rounds on Polyphagia. We are going to work through a case example to discuss some of the ways that you approach polyphagia, and for this purposes, I'm going to present you a real-life case named Sailor. Here he is. This is Sailor. And Sailor, like many dramatical performances, is a story in three parts or three acts. So Sailor, true story, Sailor is an 8-year-old male castrated domestic lawn care, and this is really him. And he had a chief complaint of chronic weight loss with a good appetite. So first thing, let's take a pause and let's think about when you're talking to your clients, what are key considerations or data that you should prioritize collecting from the owner given the presenting complaint? So in this case, knowing that Sailor is presenting for weight loss with a good appetite, what are the things that you want to know going in the exam room to think about or ask about? Because in the space of a short visit, it's really easy to get derailed or distracted. You have two owners, and the one says, oh, well, this happens 3 times a day, and the other one says, no, 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 it happens once every 3 days. And then they go back and forth, and you feel like marriage counselors sometimes. And so, you really want to know going in what are the things that you need to guide people to talk about. So I want you to pause here, and so you can go ahead and you can pause me. So wiggle your mouse or hit your space bar, and just go ahead and write down a list of key considerations or key things that you want to collect from the owner given the presenting complaint. If you're working as a group, you can just pause and spitball among yourselves, and I'll wait. Awesome. I'm so glad you guys have taken time and done that. So then the next question you have, so you're not done with your work yet, are what are some important tricks to collecting the most accurate and thorough history for this patient or any other? So what are the important things you need to know when you're trying to collect a history to make sure that the history you get from the owner is not just complete, but is truly that of the owner instead of being biased by your presentation. So go ahead and take a few more minutes and think about things that may have impacted the way you communicate with a healthcare provider, or things that you've noticed when working with clients already, or just anything at all to help you figure out the best way to get the full information but accurate information. And again, I'll wait. Great. Your very last subtask on this is how can you maximize success when dealing with a distracted owner? So you've got someone who's worried, or they've got a lot going on, or some other factors we'll talk about. What can you do to help keep them with you on the reservation, to keep them answering your questions, paying attention, instead of just wandering off into their own free space? And again, I'm happy to wait. I'm self-isolated, just like you, and I'm happy to wait for you. Okay, well, I'm certainly not going to answer all of these questions, because otherwise, what is the point in you thinking it through or working as a group? But I do want to talk about a few things that I find helpful. So these are rubrics that we use for a drop-off case that is coming into our clinic, and to make sure we collect all the information we want. And although my mouse has apparently disappeared with this capture, what you should be able to see is that we're collecting a lot of good general information, like are they having good days? Are they having more bad days? How is their energy level? But when we're thinking about a case with weight loss with a good appetite, that to me speaks to GI. And so other things I want to know is I want to know more about the appetite. So what is good? Is good normal? Is good increased? Is the change mild? Is it moderate, or is it severe? Perhaps it might even be unknown. If you've got a cat living with other cats, they may have absolutely no idea who's eating what. They just know that all of the cats sometimes visit the food bowl. And I can identify with that. I have a herd right now. Perceived weight gain was right there below appetite, and that's going to be part of the same thing. And then other GI things. So are they vomiting? If so, how often? Some people think that vomiting is sort of normal for cats, and so they may not perceive it as abnormal at all if you just ask if they are vomiting. But if you provide them with something like this and you're asking about frequency, you're going to detect that, oh, they really are having a problem there. And then the same thing with feces. Within feces, if they don't give me a normal, if they're giving me soft or they're giving me hard, then the next thing that happens is I'm going to whip out my fecal scoring chart, and so I can get a better sense of what does that really mean. And it sounds surprising somehow, but owners just love to score their dogs and cats' poop. It's really fascinating. And then frequency of bowel movement. This is often easier to determine in a dog than in a cat because of the use of litter boxes and or if you have indoor-outdoor cats. But these are important things to assess. Other things that are super common or super important to assess but super common to overlook, especially when we're talking about GI concerns, are going to be information about diet. So I can't tell you the number of times that I take consult calls and we're addressing a situation of weight loss, and I say, well, what are they eating? And they say, oh, I'm not sure. Oh, I think it's kibble. You want to really know not just what the diet is, but how much is fed and what percent they're actually eating. How frequently are they being fed, and what are their treats? If they're fed no treats at all, then that's going to be a very different situation versus if they're fed a whole bunch of treats. And finally, in addition to knowing normal medications, it's going to be really important to understand what's being done for flea tick and for heartworm when I'm dealing with chronic enteropathy cases, because often we end up going down the path of a food trial, and if they're on a food trial, then they really need to not be on flavored preventatives. So if I don't know what preventative they're on, then I could end up starting them on a useless food trial, because even if I change their diet from one that costs $20 a month to one that costs $60 a month, it's not going to help at all if they're still on HeartGuard or they're still on Interceptor. So I just really need to know what's going on there in order to be able to do my best to help them. And again, medications are the same way, with increasing numbers of flavored medications or compounded medications. So I have to have all that information. Now, I do want to circle back. I told you I'm not going to give everything away, but some important things that can help you to make sure you're really getting good and accurate information from owners is going to be, is if you look over here, and I'm sorry my mouse disappeared, but is looking to say, are things normal, decreased, or increased? The same, more or less, the same, less or more, whatever it is, you want to pick it. And you'll notice if you look all the way down here, activity, appetite, perceived weight, water intake, urination, vomiting, everything where there are choices, it's presented in the same order. Normal, decreased, increased, normal, decreased, increased, normal, loss, gain, normal, less than normal, more than normal. And the reason is if you do not do it consistently, if you sometimes do it in one order and you sometimes do it in a different order, then what can happen is that owners can subconsciously cue on that and think that there's a right answer. And so by always presenting it the exact same way, then you are allowing them the opportunity to not be influenced by their desire to help. And instead you're making sure you have the best chance of having like what you really need out of them. And then when they give you the answer to that, then you move on to, well, how much decreased or increased? Is it mild? Is it moderate? Is it less than normal? Well, what does that mean? Is it less than normal for that animal? Or is it less than normal for for a similar dog? So you can get into some of those discussions, but making sure you're presenting information in the same way can make a big difference in the kind of information you get. And when you ask these questions, after you ask them, always leaving a space where you wait for them to fill in the silence is really, really important. So, oh, normal, great. What about weight? What about, no. Oh, okay. So you think it's decreased. And if you just leave blank silence there like that, people get uncomfortable with that, and so then they fill in the silence by giving you the information you really need. Okay, what about the distracted owner? So when you think about the owner, as you saw a couple of pictures ago or a couple slides ago, it looked like, wow, this is just a loving owner and she's in with her dog. But actually this owner is here. She's had to bring all 3 dogs with her, and there's her phone in her hand because she's getting texted from her husband about the situation with the school. And so you don't just have an owner and a patient, owner and cat. You have owner and cat and 3 dogs, and husband on the phone also worrying about daycare. And so how can you help make sure that you are hearing them, more importantly, they're giving you accurate information, and when the time comes that they hear you? So a really good thing you can do that I like is to provide activities for competitors. So if there are animals that are clamoring for attention, I'm going to look at giving them treats, or I'm going to be on the floor instead of being sitting eye to eye with the owner. I'm on the floor, so the animals are crowding around me, curious about me, which is focusing the owner again on me. If they have brought a little biped with them, then I want to make sure that I've got something like coloring pages, or I will sometimes give them my stethoscope, something to keep them occupied and from being worried about the time they spend in the waiting room, so that instead mommy or daddy can pay attention to me and devote their attention to trying to figure out the answers to my questions. I also can make life easier for them with some pre-work. So I really like to encourage owners to bring a list of concerns and complaints. And a really great way to do this is to give them a structured worksheet either ahead of time or when they arrive and they're admitted for their appointment. You go ahead and give it to them. So that has time to percolate while they're sitting in the lobby waiting to step in. I asked them to put their devices on airplane mode so that all of the pings they're getting regarding the rescheduling of their flights is not going to be interfering with their ability to focus on me in the moment and for me to focus on them. And I encourage them to take notes or to audio record me. I say, do you want to record this to share with someone else? Do you want to make sure to take notes so that you don't forget when you get home? Please feel free to do that. I want to make sure that you're equipped for success. And just offering those possibilities really helps to center people and focus them and help them stay with you. I know there are tons of other great ideas and probably better choices than what I use, and so I really hope that you will share the things that you found through your brainstorming with each other, and I'd love it if you want to reach out and share them with me. Okay, so now we're going to go back to Sailor. I know you forgot all about him. So Sailor has presented for marked weight loss, and it turns out he has lost 4.5 kilograms over the last 3 years. This is 60% of his body weight. And the crazy part is this was only discovered 6 months ago at his wellness visit. And the owner was shocked when the weight was reported to her about Sailor. She had absolutely no idea how much weight he'd lost, which isn't particularly surprising if you think back, because he's a really big, really fluffy cat. And so if you got a really, really fluffy cat, they can hide weight loss pretty well. She reports that he's had a normal to really great appetite all of this time, up until not that long after his wellness visit. So he was eating fine at the time of that appointment, but since then, he's been having this progressive weird eating behavior where he seems like he really wants to eat. She puts down the food and he rushes to the bowl and then he eats, 1 or 2 kibbles. But when he does it, it's in this really weird way where he takes the kibbles up and he pulls them into his mouth, and then he's got this grinding teeth thing where he's like, and then he turns his head upside down, kind of like an owl, twisting it around, but it's upside down. And sometimes he's got these really exaggerated chewing motions, and it's really kind of crazy. And so he'll do this for a couple of kibbles, and then he walks away from the bowl. And then a couple hours later, if she shakes the food, he rushes back up, and then they go through this again. This is Sailor, and again you can see how handsome he is and also how fluffy. And if you look closely, you can see, I think his tag really says Sailor. And on physical exam, what you can see is he is in fact emaciated. He has a body condition score of 2 out of 9, and he weighs 3 kilos. He is vicious. And they just said, this is just a hateful, mean cat, and you can't get near him. But when we looked at him a little more closely and tried a little less hard to examine him and a little harder to know him, what we realized was he was really fractious when his head was manipulated. And so stepping backwards further from that, what we realized is he had really severe mandibular pain. And he actually was really fine to work with as long as you didn't get near his head. And that's because he was protecting himself from his mandibular pain. So you can see he wanted to be a chatty, talky guy. You can see his little mouth open. And so by threatening him a little bit, not in a mean way, but with a pen, pretending to bring a pen near his mouth, he would sort of open his mouth to try and bite at the pen. And when he did, we could see inside that he had diffuse periodontal recession with gingivitis. So let's go ahead and pause here, and I want you to get out your paper and your pen. And if you're working as a group, I want you all to take yourself off mute and then say, what are your current problem list and differential lists for this cat? And a pro tip for you is to always list your differentials in order of decreasing likelihoods. You always start with the most likely differential and you work your way down. So what would be your problem list for Sailor? And what are the top differentials you have for him? Again, putting horses above zebras. And then, once you guys feel like you've got a really good understanding of that, I want you to think about what would you recommend to this owner, both diagnostically and or therapeutically. And think about how that is going to be. What is your A list? What are you going to just recommend as absolute top notch? But how are you going to prioritize that if you have any financial constraints? So go ahead and put me on pause, and I'm happy to wait here as long as you need. And when you are ready, you go ahead and come back and hit that space bar again. Okay, well, what did we come up with? Well, our problem list for Sailor was that he had weight loss with a good appetite, and then he had an unrelated or current problem of dysphagia, which actually had progressed to acute anorexia. So he had dysphagia, but he had an underlying history of weight loss, but with a good appetite. On examination, he had this bad mandibular pain, and he had dental and periodontal disease. When I'm thinking about his weight loss with a good appetite, that for me, I always break it down. I close my eyes and I imagine being food. So I'm a kcal going into the body, and I say, all right, if the kcal goes into the body, well, where can the problem lie? Well, the first thing is it never leaves the intestine. So that's going to be diseases like EPI, which we used to think was only a dog disease, but has been disproven. It's actually more common than we think. It's shocking what you discover if you actually test for it. We also are going to think about things like parasites, where the parasite is stealing the K calories, and so it's not getting absorbed. Then in the intestinal wall, we can have a problem with the walls, so we have malabsorption there, so you can have maldigestion, which is EPI. You can have malabsorption, either because the calories are being held hostage by parasites or because they're not getting taken up because the intestinal wall is compromised or infiltrated. Once the kcal gets absorbed and it's zooping along in the body, you can have an inability to take it up into the cell, which is going to be diabetes mellitus. So if you don't have insulin, you can't get that glucose out of the bloodstream, and instead it just zoops along and then it just gets peed out. And so it can be that it's trapped and in the circulation and then gets peed out, or maybe it's getting taken up in the cells, but you just have too much need. And so things that I'm going to be thinking about that can cause too much need would be a super high basal metabolic rate, like something like hyperthyroidism in the cat, cancer. Cancer anywhere in the body is an excellent parasite, so it's going to be stealing all the calories the body needs. Or septics, chronic septic states can do it. So if you've got a chronic infection you're fighting, then that's going to increase your need for fighting the infection. And so that will cause increased need, and yet still you could have weight loss. So those are going to be like the top things that come to mind for me. And then dysphagia, when I'm thinking about dysphagia, I can have a neurologic problem. I could have a problem with my teeth, or in this case, the cat's teeth. There could be a problem with pain. There could be a problem with there being an obstructive process. So in dogs, we think about masticatory muscle myositis. So I'm going to be thinking about things like those. And so I'm going down that route. In cats, we can have dysphagia because they've got primary periodontal disease, like if they've got lymphocytic plasmacytic stomatitis, it just hurts too much to have things touch your gums. And so that would be another cause. It's slightly different from having primary dental disease, but you can have those things. Mandibular pain. Sailor was so painful, so painful. You couldn't actually touch his mandible, even though he was that painful. And so I had dental disease on my list, but I'm also going to be thinking about things like cancer. So could he have mandibular cancer? Could he have squame? Those things could go together with the dysphagia, but they certainly could be unrelated. And that's why I haven't lumped dysphagia with mandibular pain, is because the mandibular pain might be due to, a neurologic problem, and the dysphagia could be a tooth problem, or so on and so forth. I had a dog with dysphagia once that had a stick lodged sideways between the maxillary molars. So there's all sorts of crazy things that can happen. So until I know better, I'm going to keep them separate. And then finally, I saw that he has dental and periodontal disease. I just can't guarantee that that's really the cause of his dysphagia or his mandibular pain without more information. So I'm going to be thinking about all of those things, and those are going to be my differentials. So what am I going to do given those differentials to try and work them up? Well, our plan was to start with a complete blood count to look for evidence of infection and to look for other changes there, like anemia that could be related to chronic illness, a biochemical profile. We got to look for diabetes because that's on our weight loss with a good appetite rule out list, and look for hyperglobulinemia and other issues there. He is a cat. And so as per AAFP guidelines, it's really important that we determine his FELV, FIV status, as he is a sick cat. Every sick cat we should know, and a urinalysis. And then we had a plan because we couldn't really look in his mouth. I was teasing him with a pen to try and look at his teeth, was that if those things all checked out, was to knock him out for an oral examination, and then depending what we found or didn't find, potentially a peg tube placement, because he was so emaciated that he was really at risk of dying from that. A CT scan if this looked to be a primary mandibular problem, like we were worried about an infiltrative neoplasm, and or a dental radiograph. So it was really kind of open. It just depended on that oral exam. And there really is no substitute for doing a good exam. It's also no substitute for having a plan for what you're going to do from that exam. And so you really want to think 2 steps forward. Doing a really good job with our clinical cases is often a little bit like playing chess, which is you always want to be thinking 2 or 3 moves ahead of your opponent. And in this case, our opponent is going to be disease. So what did we find? Well, this is the complete blood count, and we can see that Sailor is a tiny bit anemic. His white count was surprisingly normal, but he did have a little bit of a left shift. So he's got a normal neutrophil count, but with a bit of a left shift. And he does not have a lymphopenia. I would have thought with all he had going on, he would have a lymphopenia from stress, but he does not. So that's kind of interesting. And he does have a bit of a monocytopenia. His platelets were clumped, but probably adequate. It was very difficult getting blood from him because he wouldn't let you near his head. And so this was a peripheral stick from a not trusting, underfleshed, not the greatest stability cat. And so it took a bit to get the blood carefully for his safety. So what am I going to do with this? Well, I'm going to say I don't really understand why his neutrophils aren't higher. It's possible he has a neutrophil sink somewhere, especially given his bands. I don't think it's a matter of this as being per acute. Given the changes I'm seeing in his mouth, I would have expected there to be some inflammation. So is he got a sink somewhere, or is there some reason he's not mounting an appropriate immune response? The lymphocytes is like, I don't really know too much to do with that. Could that be a combination of stress plus chronic inflammation? So stress is pushing him down, chronic inflammation up. I just don't know. And then, of course, he's got his mild anemia, which gets to, this is not an right now problem. This is a bigger picture, longer term problem. On his chemistry, he's got a low normal BUN and a low normal creatinine. This doesn't surprise me that he's got a low normal BUN and this is an emaciated cat. His creatinine also is low for that reason. He's emaciated. He's currently anorexic. He's holding his own with his albumin, so that's kind of good. You see I've provided you with lots of liver values that are mostly normal. So he's got a normal or borderline BUN, or I'm sorry, bilirubin. He's got a borderline ALP. He's got a high AST, but the AST we're going to blow off because of his CK. And then he's got a notable ALT, which is, really quite impressive for a cat because they have a shorter half-life for ALT than dogs. So we're looking at those things really carefully because of his acute anorexia. We're going to be worried about hepatic lipidosis. In this case, studying him and studying all his pictures, I say, you know what, let's keep going. And because, but this is pushing us a little more towards thinking about putting a feeding tube in. The ALT activity could be confounded. We haven't seen his mouth yet. We don't know how much of this could be a reactive hepatitis or reactive hepatopathy is more accurate, related to his dental disease or a lack thereof. So we're going to just wait and see. But we definitely are on the ready, and we do have approval if we need to place a feeding tube. And then finally, we've got a urinalysis here, and we can see that he's not fully concentrated urine, but you'll note I did not tell you what kind of food the cat is eating. And so you don't know how much at this point in time he's eating of canned food versus kibble, and how much that could be influencing his specific gravity. He does have a dipstick protein of 2+. I know some of you are expecting the very next thing I'm going to do is tell you what his UPC is, and I'm going to tell you I didn't run one, and the reason is going to become clear in just a minute. We did an FELV FIV test and it was negative, and so we sedated him and we did an oral exam. And on oral exam we found he had generalized periodontal recession. He had mild exudate pooling around his teeth, and he had a moderate proliferative ulcerative stomatitis. Now, he had this mild exudate pooling around his teeth and that moderate proliferative stomatitis. Well, this is, the ulcerative stomatitis is going to be an inflammatory disorder, so I'm expecting this cat to have proteinuria, because that's going to be an appropriate response of altered glomerular perm selectivity. So seeing his mouth, I said, of course this cat's inflammatory, of course he has proteinuria. I'm going to wait to characterize that. I'm not going to spend $60 on a UPC now. I'm going to try and fix his problems. Once I fix his problems, then I'm going to circle back and see if it's still there. And so what did we do? We did dental radiographs, and on dental radiographs and probing, we discovered that he had abscessation of pretty much all of his teeth. So when we probed the first tooth, and pus just exploded everywhere. And the long and the short of it is that he ended up with almost full mouth extractions. We left behind exactly one tooth, and the only reason he got to keep that one tooth is because he had developed refractory hypotension and hypothermia, probably because of the massive bacteremia associated with his teeth. We ended up we sampled that for culture, and while we were waiting it, we started him on intravenous antibiotics and then put him on clindamycin for 14 days. The culture from the tooth root abscess grew a mixed population of bacteria, but they were sensitive to clindamycin, so we made no changes in his antibiotic protocol. Once we got him out of the hospital and home, he seemed to be doing well on follow-up phone call a couple days later, and so that was the end of this visit. So the owners wanted to give him a little more time to recover, and so they didn't bring him in until 30 days. So he's finished his clindamycin, he's gone another week and a half, 2 weeks, and they were so thrilled because Sailor was eating great. He was just eating great. And so, but maybe he was eating a little too much. Like, how great is great? And the funny thing was, although he was eating great, they thought maybe he was continuing to lose weight. Oh yeah, and by the way, he's actually having intermittent loose stools. This was first noted 10 months ago, doc, and at that time he was treated with sulfasalazine, and he responded. And, we did all of that questioning before. We talked about the questionnaire, and of course it didn't come up then, but here it is now, that their memory has been jogged by him having it now. They remember, oh yeah, this has happened before. So this happens to all of us. It is not a student phenomenon of going into the room, getting one history, going back and getting another one with the doctor. This happens to everybody. And this is Sailor at the time of his next appointment. You can see he looks a little bit blurry. So let's pause for another minute, and what I want you to think about is, how do you differentiate when good or great actually is excessive? And in this, the context of this case, we're going to be thinking about, well, how do you know when an appetite is really good versus is that polyphagia, or is it excessive? But this equally applies to things like urine output. So owners will commonly say things like, hey doc, yeah, I know his kidneys are working great because he makes a lot of pee. And so people often confuse excessiveness with goodness. And so how do you differentiate? So I want you to think about that. And then after you guys have talked about that, what I want you to tell me is take a few minutes and do some math. So if Sailor was fat originally, and we were to say his ideal body weight is 5 kilos, and his food has a caloric density of 220 kcals per cup, which would be consistent with many of the canned foods, how much should he be eating to maintain a 5 kilo weight? So if he should be 5 kilos and his food has a caloric density of 220 kcals per cup, what should he be eating? How much would be normal? All right, you take a minute. I'm going to just hang out here and space bar me. And then when you guys are ready, you go ahead and come back and click back in. Okay, wonderful. Now that we've done our math, we can move on. Here we can see Sailor walking about. You can see he's a little bit slouchy. You can see he's really, really poofy. You can see his hair has not regrown from his cephalic catheter, from his dental yet, but it's coming. And you can really appreciate with all that poofiness how easy it would be for silent weight loss to hide. This was taken at the time when he was still massively cachexic, and he looks really pretty great from a distance, doesn't he? So what did we notice? Well, we noticed that he was very hyper but loving, which is a relief, because remember, originally people thought he was a shark. But he actually, now that he doesn't have all that head and that mouth pain, he doesn't have all that mandibular pain, he is just a Romeo of a cat. He's a lover. But, you know, we really had a lot of trouble getting him in focus. On examination of his mouth, which he happily let us do now because it didn't hurt, his stomatitis was completely resolved, so all of that caudal fasciitis and change was gone, and his one canine appeared very healthy, his happy little snaggle tooth, as his owner said. But he's lost more weight. So he's now down another 0.2 kilos. And that doesn't sound like much, like 0.2 kilos. But you have to think about that. That means that he's lost, almost half a pound in a month. And if you look at what he weighs and you compare that to, say, what you weigh or to what I weigh, and you do the math or that you do the translation, that's actually, a pretty concerning amount of weight, assuming it's not bladder. And I'm going to promise you it's not bladder, because on exam, before he'd been maybe on the high side of a 2, now he's a 2 out of 9, but it's questionable whether really we're being generous there, and he might be more like a 1.5. So when we discharged Sailor from the hospital, his problem list was weight loss with a good appetite, lymphocytic plasmacytic stomatitis, and tooth root abscessations. Now, how has this changed? So go ahead and write that down, and then I want you to work through what you know about him now to figure out what are your new problems and differentials. How are you going to figure it out? And if the owners have financial constraints, which of the tests on your list would you run first and why? It's very easy to get conditioned when you're in the ivory tower or you're working in a teaching institution or learning in a teaching institution, that people just hand you their animal and a blank check. But the reality is very few people can do that on a day-to-day basis. And so it's very important that we be prudent financially. We want to think about, can we stage things? And if so, what comes first? And it isn't necessarily the cheapest test. It may be the highest yield test. It might be the least dangerous test or the least invasive test. So you have to think through those things. The other things you want to think about are prevalence. If you run every test on every patient, then suddenly the positive predictive value becomes very, very low, and the likelihood of a false positive becomes very high. So go ahead and take a few minutes, and I want you to work through this and think it out. Okay, so for me, I am resolving or inactivating the problems of lymphocytic plasmacytic stomatitis and tooth root abscessation. So on my master problem list, I'm going to put resolved in today's date. And I do still have a problem of weight loss with a good appetite, but I'm adding the new problem of intermittent loose stools. I'm not loving this problem because I don't really have better characterization. I want to know, is it large bowel, is it small bowel? But I'm unable to get that from this owner. She uses clumping litter. She doesn't want to see it. She doesn't want to talk about it. She has her husband scoop the litter box, and her husband is not allowed to have an opinion. These are some of my favorite people in the entire world, and it works for them. So this is what I've got. So we really haven't got a lot of changes in our weight loss with a good appetite problem. We've really made no progress there other than to rule out that it really was weight loss with apparent good appetite but dysphagia. So that it's weight loss where the animal wants to eat but can't. We know that's not true. He really is eating, but he's having weight loss. And then we now have this new problem of intermittent loose stools. I can't characterize it anymore, so I'm going to go with GI versus extra GI. And my extra GI is going to be pretty limited given his prior lab work. So I'm going to be thinking about parasites. I'm going to be thinking again about EPI. I'm going to be thinking about chronic enteropathies, such as food responsive disease or probiotic responsive disease, and work my way back from there. So what did we do? So our plan? Well, we decided or recommended to repeat a complete blood count, biochem, and urinalysis. And we added on a T4, total T4, and recommended fecal flotation by centrifugation as a good starting point. If I were to be picking and I wasn't in the ivory tower, I probably wouldn't be doing all of these tests. I would be prioritizing. I'd be really interested in adding on the T4 and the fecal, and then I would probably be looking at that complete blood count to try and figure out what happened to the white count and the anemia. But I might stall on checking the biochem and the urinalysis because I know he's still broken. So I'm not going to be too worried about if he still has a little bit of persistent proteinuria yet. And I didn't see anything on his biochemical profile that was a major red flag before. I'd love to recheck all that liver enzyme stuff, but he's been eating really well. And so, which is why we didn't end up, once we removed all of the pain stuff, I never told you, I'm sorry, we didn't end up putting a feeding tube in him because when we dealt with all of the teeth, he wasn't doing well at all under anesthesia, and we also knew we'd removed a major septic focus as well as a pain focus. And so we said, you know what, let's get him up, and if he doesn't eat, we'll knock him back down for an E-tube. And he actually ate great, and so we said, let's leave it alone. So I'm not anticipating his biochemical profile is going to change in a way to make me think hepatic lipidosis. I want it all, but if I have to dicker, I'm going to be prioritizing the things at the bottom. Luckily, these owners being amazing, authorized everything. And then, if I get all that back and I'm still not finding things, I'm going to circle back around and start doing my chronic enteropathy workup and be starting with TLI and cobalamin and folate. So complete blood count. Well, his crit has actually come up, which is great. It suggests that removing that septic focus is helping him. He's not fabulous, but he's headed in the right direction. And his white count has come up with an increase in his neutrophil count, but a resolution in his bands. So this says that a lot of his neutrophils being in the middle of the reference interval instead of being higher like we might expect with stress is going to be because of him having a neutrophil sink where the neutrophils are continuously marginating into his sulcus of his teeth, his sulci. And so that is corrected. He's pretty darn hyper, so his lymphocytes are still up. I don't know if that's an epinephrine response or if it's ongoing inflammation. His teeth look great, so if there's inflammation, it's probably somewhere else. On his chemistry, we can see his BUN has come up quite a bit, but his creatinine is holding. I don't know, this could well be partially, it could have been because of GI bleeding, not from his gut, but from all of his teeth being pulled and all of those healing sulci, so that could be part of it. We can see his albumin is starting to climb a little bit, which is nice, and he's had resolution in his liver enzyme activities, which is wonderful and suggests that in fact his liver enzyme pattern was related to a reactive hepatopathy. And finally, on urinalysis, he is still minimally concentrated or mildly concentrated with a little bit of protein. He was at this point in time receiving canned food, so I'm not freaking out too much or going to chase too hard on that 1022, and I know he's still recovering from having basically all of his teeth pulled, so I'm going to allow him to have a pass right now on that protein, but I'm keeping my eye on it, I promise. And then we got a T4, and his T4 came back as 61. We were unable to obtain feces for evaluation, and his owners had not brought it, and were unsure that that was something they were willing to do in the moment, which I respect. And so this is what we have. So I want you to stop and take a minute and think to yourself, is there any additional testing necessary to make a diagnosis? So do you feel with his T4 that you know what is going on, or do you need some additional testing to feel comfortable? And what are the positive and negative predictive values of that test versus adding something on? And once you've answered that question, I'd like for you to take some time to work through the potential treatment options. So there's a number of options available for treating hyperthyroidism, and so what are they? What are their advantages and disadvantages? What are their risks? How does the one play off of the other? Are there things that are going to help more in the short term versus the long term? What type of follow-up monitoring is going to be required for each of your options? And what other factors might influence the owner's decision regarding treatment? So it's not necessarily as simple as you can do A or you can do B or you can do C, but there are other things that can come into play. You know, if you have a multi-animal household, then something that requires isolating one animal, that can work in some households, and in some households it can't. There's a lot of things that go into play here that really need to be considered in having this conversation about options with the owner. So I want you to take some time, enough that I want when you pause this video right now, note how far you into the video. Because if you note where you are in on the video, like how long I've been yammering at you, then after you go and you do your research and you pull the papers to try and answer these questions, when you come back, you're going to be able to just zip that thing along right back to where you were to keep going. So you don't have to leave me pause that whole time if you don't want to. I mean, trust me, I'm self-isolating at home with a 5-year-old. If you want to leave me pause for 2.5 hours, that's winning for me. I could use a 2.5-hour pause. But if not, if you want to go away and come back, just note the time on the video and you're good to go. Okay, so what did we end up doing? I'm not going to tell you the answers to those questions because you're all experts now. So I'm going to tell you what we did. So Sailor came back 14 days later and he was doing well. The owner thought he was just doing great. He, at this point in time, 14 days in, he is on methimazole at 2.5 mg BID. The owners report that he is less hyper and less vocal, and that is supported by the fact that he is now, we can get him in focus. You can see in this picture, we can get him in focus. He's still just like the most handsome cat ever. But he's lost more weight. He's lost another 0.3 kilos in 14 days. His appetite is unchanged, and since his last visit, he's had persistent diarrhea. Oh man, this is really irritating. Jiminy. What did we do? So I'm going to tell you what we did, and you're going to know, I hope, why we did some of these things. So we know right now he's 14 days in on methimazole, maybe perhaps a methimazole trial. We're checking a complete blood count. We can see his hematocrit has actually come up a tiny bit more. His neutrophils are stable with no bands. His lymphocytes are solid. His monocytes have normalized. They'd been a lot higher. Now they're kind of a little more where we'd expect with a sort of mild monocytosis. And again, his platelets are clumped. On his chem, we can see that although he's been on methimazole for 14 days, his creatinine remains normal. His BUN is up maybe a tick. So he's got an increased BUN with a normal creatinine. That should be ringing some bells for you. He has a normal albumin. He has normal liver enzyme activities. He continues to have this bilirubin that's apparently 0.1 above the reference interval, but has not moved at all. On urinalysis, he's still running at 1022. His protein is down to trace. So this has been slowly going down. Remember, it was 2+, then it was 1+, now he's at trace as we've gotten further away from his teeth. And so that seems to be heading in the right direction. So we did a T4. Oh, and he's still 1022, right? So we're checking. We've seen his kidneys are doing well, but he's got a weird discordance in BUN to creatinine. His CBC, he's got a good crit, and all of his other cell lines look good. His urinalysis, his specific gravity is not worse, and his protein is better. His T4 comes back 21, so it comes back normal. So now what? What do you do with this case? We have spent like, I don't know, $2,000 on him dealing with his teeth, his dental, radiographs, he's had all this lab work. He went away, he came back, he's been on all of these other, got tested, got diagnosed with hyperthyroidism, he's been started on meds, now he's got all this lab work, he's got a normal T4. So now what are you going to do? And so your first stop when you get in this place is to not freak out. So it's that sort of stay calm and meme that you see. So stay calm and revisit your problem list to see what differentials and diagnostics, there's under the pencil, I'm sorry, is where it says tests. What differentials and tests remain unexplored? And then what are important considerations in discussing test results and next steps with the owner? So, you're feeling frustrated. We're entering Act 3 with this cat, and the primary problem, the reason she came to see you from the beginning, has not been fixed for a cat that she has clearly and repeatedly told both you and the husband is more important to her than the husband. And they were both fine with that, the cat and the husband. They both liked their places in the family. What are you going to do? How are you going to approach this with her? And a really helpful thing is to role play these different potential approaches and owner responses. And you can do this, if you're working as a group, this is wonderful. It's an opportunity for you to play out every character you want. And if you're doing it yourself, then, you can just play it all out in your head or write some things down. Or ask somebody who's stuck in your house self-isolating with you to help to work through it. This is also where it's super valuable to really maintain continuity of care. So I cannot tell you how strong an advocate I am for always seeing your own patients. Because if you always see your own patients, you know your people, you love your people, and you understand your people. And so you know how to speak their language. So I'm going to speak a very different language to Tracy, to Sailor's owner, than I might speak to the owner of another patient, like Dog Latimer's owner. They're all different. And so being able to know them allows me to really be with them in the trenches and keep us all on the same page and on the same team. Now, you also need to think about, because we're now in like quite a bit of money, how your recommendations could be adjusted based on financial constraints, because everyone eventually has a limit. And so you want to be thinking about that in the front. That does not mean you do not offer what you believe in. You always offer what you believe in, and you always wait. one of the most common mistakes I see for young vets is that they make a recommendation to an owner, and the owner just has like 1 second to start thinking about it, and then they offer a compromise. So they'll say, we really should look at doing wellness blood work, and that'll be $250. And the owner's pausing because they're trying to think about when they get paid and where the money is, and they go, or we could just go ahead and do a heartworm test. And you don't want to do it. And what I found really helpful, especially when I was a young pup in general practice before I specialized, is leave the room. So I'll say, our recommendation, we've hit 9 years of age, and this is where we begin wellness blood screening, is that we should go ahead and skip those vaccines. Your animal needs no vaccines today, but I really should look at starting to implement wellness screening. It will cost this amount of money. I know it's a lot of money. This is why it's important. And I know because it's a lot of money, you might need to think about whether this is going to work in your budget right now, or you need to do some planning for it. I need to go check on a test result, and I will be back. And then you just leave the room and you give them 10 minutes. And you'd be shocked the number of times when you give people a little space to think, how resourceful they can be and how much they can know the right thing and make it work. So I want you to be thinking about how can those recommendations be adjusted. And so you work on those. Let me see if I had another ball. There it is. And then your last thing, once you've figured those things out, either yourself or as a group, is to say, when should you start considering referral? So are you tapped out, or do you personally have more to offer failure? Is it time for you to say, you know what, Tracy, I think maybe I should send you someplace else? Or are there still things that you can offer where you are providing the best care? So go ahead. This is a lot. I know this is a lot. So go ahead and take some time and just space bar me, and I'll be here waiting when you come back. Okay, so what about me? So when I look at this case, what I have is a cat that has active problems of hyperthyroidism and active problem now, because he's now got persistent diarrhea that is extended more than 3 weeks, for which we currently have no explained cause of chronic enteropathy. And so that's the definition of chronic enteropathy. And when I look at him, I see 3 very appropriate courses of action. So the first course of action is to go ahead and continue diagnostics and workup. And so this is going to be completing my workup for chronic enteropathy, things we talked about earlier. We've got our TLI, B12 and folate. We've also got our fecal flow, wet mount and direct smear, abdominal rads, and ultrasound. So we can go ahead and do all those things and see what we see and see what we don't see, depending where you live in the country, or if you're in this country. You might also want to be looking at a histoplasma EIA. That would be another thing that might be in there. So go ahead and continue that workup and see what you find. The second option would be to try an empiric treatment trial. So things that you can consider, that 60% of cats with chronic enteropathy are responsive to diet. So go ahead and do a food trial. The other thing that would be very reasonable is that she didn't remember about his historic loose stools until after we treated his teeth. And when we treated his teeth, what we did is we cut out all those teeth and then we put him on an antibiotic. We put him on clindamycin, which is remarkably good at causing dysbiosis and may have caused an antibiotic-induced chronic enteropathy. So we could consider giving him a probiotic trial. And in either of those cases, if you do diet or probiotics, then you see what he does and you can circle back. And if he responds, wonderful. And if he doesn't, you go up and you do step 1 of continuing diagnostics and workup. Or you do step 1 and step 2 simultaneously. Of course, if you don't have some of these tests that you feel that he needs, like you feel that you're not sure, maybe you're feeling something segmental in his bowel, but you don't have abdominal ultrasound, it's an excellent time to consider referral, because this is an opportunity to get clean eyes on the case and have them look and see what they see, or to have tests that you don't have. So those are all very reasonable approaches. So he was with a referral specialist. He was with me by now, and this is a case from after I'd crawled back into the ivory tower, so I couldn't really punt him somewhere else. So number 3 was kind of off the table at the moment, but I will tell you, if I have cases where I'm stumped, or things aren't going the way I want them to, I actually do make them referrals internally. So I set them appointments with someone else on internal medicine, and I ask them, the doctor in advance, to not look at my records, just because I want them to approach it with a clean eye. I try to make sure to pick someone who thinks differently from me, or I ask somebody, a colleague who thinks differently from me, to give me a consult and see what they find that I'm missing. So just because I'm here in the ivory tower doesn't mean I can't do a referral. But in this case, I felt like I should be able to handle this. I do have training in this. And so what we ended up doing was a combination of 1 and 2. And so the big thing we ended up doing was we proceeded, at the time, we didn't know as much about antibiotics, so we put him on a diet trial. And so a month later, what we found was his appetite had normalized. So instead of eating 3 or 4 times RER, he was now eating what would be appropriate for his target weight. His fecal score had gone to 2, and he had gained 0.3 kilos. So he's now making gains back. You can see him looking a lot fatter. Now he was on rabbit and pea as his diet trial, and he was getting methimazole tablets and doing great. And he went on, I'll tell you, to get fat, where we had to have the owner restrict his diet because he was doing so well, and lived a very, very long time and had a very, very happy life. So I want to say thanks, and you can see here I am, and I look suspiciously like that distracted owner because that was me. That was me in self-isolation, being infested by dogs. And I want to thank you for joining me here in this time of isolation together, and I hope you've enjoyed this case experience and that it will help you continue to grow as a clinician. I know things are really, really scary right now in a lot of weird ways. It's scary watching what's going on for other people. It's scary not being connected. It's scary wondering, oh, am I going to be as good of a doctor as I could have been if this hadn't happened? And I promise you that we can't know what's going to happen, but we can know that this is not going to interfere with you being an amazing doctor and an amazing clinician. And actually, it's giving you a wonderful opportunity no one else has had, in over 100 years. In that we can use this and we can grow from this to all be better. And I'm thinking about you, and I'm here for you, which is why you're probably hearing a lot of umming, because it's the middle of the night when I can stream this while my 5-year-old's asleep. So there you go. Do the 5. Keep more than 6 feet apart. Wash your hands all the time. Cough into your elbow. If you're sick, stay home. And if by chance you are a veterinary educator and you want to do this yourself, I can tell you it's not bad at all. It's a little daunting at first, but it's really pretty cool. And so I want you to go ahead and send an email to vicerounds@gmail.com. I also want to thank the people at University of Florida who started this process. I think it's a wonderful opportunity for us to all help reach out and support each other and grow and care for each other in these times. And I'd like to thank them for kicking this off and for doing the heavy lifting behind the scenes. So with that, I look forward to seeing you in another Vice Round soon.